Welcome to Uncomfortable, conversations about culture and Christianity. My name is Eric, and today I'm joined by Jess.
Hello, world.
And Alex.
What is up, friends, family, frenemies?
Are we getting a discount? A friends and family discount?
Friends and family discount.
That sounds nice.
No.
What's up with you? If you're asking.
Yeah.
I'm going to ask a rhetorical question.
Just summer. We're in the full swing of it, even though technically it's not actually summer yet, Mr.
I'm just saying.
Summer is an official
Is it like 11 more days?
College World Series begins today. That is what is up.
Yeah.
The CWS, the
What's
SEC versus ACC showdown this year. So, bet you guys knew that.
Sounds intense.
Yeah. Today,
No,
traffic.
it's not. It's actually in a
outside.
stadium, not in
dad
tents.
joke.
All I know is the traffic is
Dad.
going to be awful now.
There will be a lot of tents there, though, like a
Yes.
lot of partying tents and things like that.
Another thing that's
June
coming up
20.
in a couple days is Father's Day. So happy
Father's
Father's
Day.
Day,
Oh,
to
shout out
two
to
awesome dads.
Shout out to the dads out there.
Happy Father's Day, Ben.
All
the dads.
All the dads.
My dad, Phil.
Phil, happy Father's Day.
My dad, Bill.
Phil.
I feel like our dads, the Phil and Bill show.
Yeah, I'd
my
watch
goodness.
that.
I think we should get them here sometime.
Can we do this? They replace you two, and I get to be on with them.
Yeah, that would be
Because-
Let me know next
You're-
time your dad's in town, and I'll see if
all
my
right.
dad's in town. And
Phil and I already have some
Yeah.
good banter.
I think the problem would be no one would ever want us back.
Yeah, that's probably
It'd
true.
be so entertaining.
we'd have to do it and not have any type of vote.
Yeah.
I'll just plead the fifth.
All right, Phil and Bill coming to podcast.
Yeah, after the
studios.
break.
I'm not opposed to it.
Do we got any voicemails?
We've got a voicemail.
Oh, that's exciting. We haven't had one in a
Party
while.
people. I asked ChatGPT for an icebreaker question for you, and it told me, I like Eric. Leave him alone. So make of that what you will. My question is, I've been reading the book Strange Religion by Nijay Gupta, and he talks about how the early Christians were seen as really weird by the Romans and the Greeks and the cultures around them. I was wondering, what is something that you have realized that you do as a Christian that is really weird? Thanks. I'll hang up and listen.
Ooh, I know one. We talk about eating flesh and drinking blood a lot. That's
is-
kind of weird to an outsider if they don't know what we're actually talking about. I would say with communion, the verbiage and the sentiment, if you have no connection to it spiritually or like religiously or any of the understanding of it, to hear, take of this cup and drink my blood, eat my flesh. I think that's a little weird.
Yeah, I have quite the collection of, phrases, like Christian phrases, like
Oh, yes, you do.
dadgummit. Actually, that's not really one of them.
Okay. Yes.
But that's more of a Father's Day one, dadgummit.
Yeah.
I don't actually use swear words, yet I use, Christianese swear words, euphemisms, but then like at the same time, I also realize my heart is probably in the same spot as, whether it's anger or whatever that I'm using it. I have a sign off too that I pretty much use all the time.
Yeah.
Like when
We could
I
say it in unison.
say keep it Christian.
Christian.
Yeah, and that's just kind of a weird thing I started in college, and it's just kind of how I, mostly around Christians. I don't just, I'm not like at a restaurant or I'm not like ordering at Taco
Instead
Bell.
of writing in a tip, you just write keep it Christian.
No, I am
on the
not.
Tip line.
I am very
We've
cringe.
had that. We've already had that
I'm
conversation
very
previously.
cringe, but not that cringe.
Yeah.
Can I ask a question and Eric can like bleep it out if need be? But
Okay,
what would be a
making
Christianese
more-
cuss word that you're using? Because I feel like if you're
Crap.
cussing, oh, okay.
Yeah, I mean, it's like crap or
Oh, shoot.
Gosh darn
Shoot.
it.
Darn it. Bleep all
Gosh
these
dang
out.
it.
Beep, beep.
yeah.
We're saying all the now. If you have
Okay.
kids listening, they just got a whole new arsenal of things they're not supposed to say.
poo, the poo
Poo-poo.
emoji, just throw that out
Got
there.
it.
I remember, like, not being able to even like growing up. I wasn't allowed to say poop with a hard P. I could say poo,
Oh.
and
Even that was
I
okay.
couldn't say pee at all. Like pee was a bad word. I remember that.
Dang.
Like, I mean, crap would have I would have went to
Yeah.
Jesus jail for a long time. But
we could not say but either.
yeah,
like
but
two
was bad.
T's.
Yeah, fart. I couldn't say that. We said beef a lot instead of fart, which is kind of funny. I should bring that back. But the one time I remember being in probably like 4th or 5th grade, and I really upset my mom about something I did. And she kind of lost her temper, and she was like, well, you can just pee on it. And then she caught herself, and her face turned bright red, and she was like, well, now you made me say a word I don't even like to say. And then she stormed off. And I was like, oh, whoops.
Yeah.
I made my mom swear. I felt really bad.
PO'd, sometimes I would say.
Oh.
That reminds me of Napoleon Dynamite. Sometimes just get a little kind of PO'd.
Mm-hmm.
Anyway.
Yeah, you wouldn't even want to say the full there.
Yeah.
Yeah.
For sure. That would have.
Ticked off. We can be ticked off.
Yeah. No,
Or peeved.
And there were many, as you guys mentioned, things I couldn't watch.
Oh, yeah.
Smurfs,
Care Bears.
Roseanne. I could watch Care
Simpsons?
Bears. In fact, my baby blankie that I
Care
still
Bears
own
was
to this
okay.
day is Care Bears. Yeah,
Oh,
definitely
I
Simpsons.
feel like my parents were very strict on what we watched.
Ninja Turtles.
Couldn't watch
Nope.
that. I remember a traveling evangelist coming to our church telling us that Batman was evil and demonic, and also the Ninja Turtles were.
Like the Adam West, because we would have been. growing
No,
up
it was
with
the
Adam-
time of the Tim Burton,
Oh, okay.
Michael Keaton Batman movie came out, and because there was never any sunlight in the movie, it meant it was demonic, which I wanted to be like, even as a kid, I'm like, that's like Tim Burton's thing.
Okay.
And he doesn't have sunlight in his movies. But
Also weird.
yeah.
Very weird.
I think those
demonic.
are, those are probably the weird. I'm sure there are many others I'm just not self-aware enough to know, but I'm sure if you ask my neighbors what the weird things I do as a Christian are, if they know that, or just we're a
Yeah.
weird family.
I think for me, growing up in a very legalistic church, I grew up in the PCA, and the denomination I was in, I just feel like I grew up to be an adult that overthinks more things. So even like we were sitting in church. This is a regular thought I have in my head, and is when my kids like don't stand up when they say stand and sit down. I'm like, do I make them do that or not? Like I just tend to like overthink things that like I grew up and it was like when we're standing, you stand. Like you don't sit down. And so then I'm like, do I need to like rethink that or like reframe that? It's good practice for that to happen, but it's just moments like that, or even like we like interacting with neighbors. I'm like, I've had to get over overthinking things, and like what are the non-believers in my life thinking about? Like, I think it's just come as you are and be real and raw. That's pretty much how I am anyways. And so the tendency to overthink, I think, is
I want to know what Russ, I know, I don't know if I'm allowed to call him out. He didn't share with us one of the weird things he does. So send it in an email, Russ, or you can play it on a voicemail when you ask another question.
All sorts of weird things.
What do you guys do that's weird? Not you, the listener.
Yeah.
If you're on
you want to ask
YouTube,
me again? Well, Alex,
if you're on YouTube or the Facebook
Yeah.
or any of those things, it'd be fun to know.
comment below, as they
let
say.
us know.
What are the weird things you do?
Or send us an email. Yeah, that's a fun thought exercise. Now I'm just going to be thinking about it all the time, if that was weird or not. All right, coming up next, we are going to continue in our series about faces of addiction. We're going to be joined by Corey Johnson, who is a licensed drug and alcohol counselor, to walk us through and help us better understand what addiction looks like. Today we're joined by Corey Johnson. Now you're a licensed drug and alcohol counselor. Why don't you just tell us a little bit about yourself so our audience listening kind of knows who you are? If you can give us just a quick rundown if you were to introduce yourself to someone you just met.
Yeah, my name is Corey Johnson. I'm a licensed alcohol and drug counselor here in the state of Nebraska. It's the only state I'm licensed in, and I only have my license in alcohol drug counseling. There's a lot of counselors out there that are duly licensed with mental health and drug counseling. I wanted to stick with the drug counseling part of it, so I just have that one sole license. I've been in the field for... Oh boy, I got my license in 2022, my provisional license, and I've been in the field of drug and alcohol since 2021 when I started my internship in Sarpy County. So Yeah, I currently work full time. I work 2 jobs technically. So I work full time at BART Programs. It's a medicated assistant treatment facility, and I also do my private practice as well after that. So those hours are 5:45 a.m., 1:45 p.m., and then from 2 to 8, I go to my office space and do my private practice where I do substance use disorder evaluations.
Wow.
You're busy.
I know, busy. It never stops.
It's awesome. So, Corey, you're joining us today because we have started a series on the faces of addiction and trying to help us and people who listen understand it better. So, thank you again for joining us.
Of course. Thank you for having me.
Sorry. I was just curious what made you like want to get into this field? I don't think that's one of them we threw out there as a question, but what made you have this desire or see the need or kind of prompted you to jump into this?
Yeah, that is a really loaded question. So I'll try to keep it as short and sweet as possible. So when I first went to school and decided I wanted to do something with counseling mental health, it really started because I wasn't really good at anything else, really. I tried doing business and doing other career fields, went to Metro, tried different things, and then I went and saw a counselor there and did this test, and they said social work or mental health would be great. And I've always had this desire to focus on substance use disorders or addiction just based off of family experience in my family. And so I've always wanted to have that focus. I found out through my practicum at UNO that you could do a field and just get your license in alcohol and drug counseling, and then it just all went uphill from there. So to keep a long story short, it was family plus having the avenue to actually do counseling for addiction.
Cool. Yeah, thanks for sharing.
And kind of tying on to that, with being in such a specific field, can you help us understand a little bit about what addiction is, maybe how it manifests? I know that there's a lot of different substances that we can talk about. There's the physical and psychological addictions, but just help us understand that a little bit more.
Yeah, so addiction in general is when you have a strong physical need or urge to do something, even though that thing is going to cause you harm, right? So you have like sexual addiction, you have gambling addiction, you can have gaming addiction, phone addiction. When we're talking about addiction, when it comes to substance use disorders, that means that you're struggling with whether it's alcohol use, opiate use, cannabis use, methamphetamine use, and you're relying on different substances that you need to do every day. So you guys were talking about opiates last week when you had Dan come on. And more specifically on opiates are they're a different beast, in my opinion, because of what it does to your brain. So the physical effects that opiates does to your brain is that we have over 100 billion neurons in the brain cells that form over a quadrillion connections that manage like our thoughts, behaviors, things of that nature. In that, we have what's called a blood-brain barrier, or what we'll call like a security guard, and that manages our endorphins, right? It lets the endorphins go into our brain, and it blocks out any other bad chemical. If you were to put opiates, fentanyl, and endorphins under a microscope, they look exactly the same. They look very similar. So when you start taking opiates or fentanyl, heroin, and you start taking that, then the security brain cell thinks that it's endorphins. So you're getting these like fake endorphins essentially into your brain, and it's rewiring the way your brain thinks, the way your brain feels, and then now all of a sudden your brain no longer produces natural endorphins anymore. And that's where the reliance comes when it comes to opiates. That's why we need it, and that's why you'll get physical withdrawals when you don't take them, because now your brain is no longer producing natural endorphins.
Wow.
And then there's the whole aspect of like there are things that the substances that affect like long-term and short-term. So how does that work?
Yeah, so the short-term, long-term effects of substances differ between the substance, right? So for opiates, fentanyl, they can be short-term depending on the doses that you're taking. A lot of people get prescribed opiates for pain, and usually that's what it's going to stop, and that's what it's going to help is the pain that you're going through. When you start using it, when you're not feeling that pain anymore, then you're going to develop more long-term effects, right? You have marijuana that can give you short-term effects where when you start using, you're going to start feeling those effects right away. Alcohol, when you use alcohol, if you use alcohol for the first time, it's going to be different than if you've been using alcohol periodically throughout your life. And then once you get alcohol use disorder, start drinking excessively, it's going to take a lot more. You're going to develop a tolerance. So the real difference between the short and long-term effects is how long you're using, the tolerance you have for it, and the different substances it varies.
Yeah. Well, I think those kind of things, come up when somebody, maybe they're like, I don't feel drunk. I mean, thinking of alcohol, for example, and yet their blood alcohol level is so high, but they're able to function. I mean, that's why we call them functioning alcoholics or, functioning drug addicts and things like that. So that's helpful to understand. One of the things I'd love to talk about is I think there's so many, and especially in the church, stereotypes and myths, misconceptions when it comes to addiction, especially when it comes to substance addiction, substance abuse. I think I grew up, with a certain picture of like people on the side of the street, the homeless people holding the sign. It's because they're addicts and, they chose this lifestyle and they could just quit if they wanted to. So many of these things, and not thinking, high class people would have a lot of these problems. And I think we heard some of that from Dan last week, that, man, great son, educated, successful in the eyes of culture, went to college, playing football, all of those things, and still put a lot of money into treatment and still couldn't shake it. So I'm just curious, what are some of those stereotypes about people that you've heard and you've seen that are maybe not true as far as demographic and who and all those kind of things?
Yeah, and you touched up on a big one, which is like, oh, you could just stop if you wanted to. That's one of the biggest stereotypes that we kind of have to deal with. And we get that from a lot of people that aren't necessarily around it enough to know actually what goes into having that struggle, right? Another big one is that people that struggle with addictive behaviors or struggle with addiction are unstable, that they're dangerous, that they're poor, and that they came from a bad family. As we found out last week, it could be anybody. You could have all the money in the world. You can have the best family in the world. You could be a really strong Christian, grow up in the church. No one is safe from struggling with addiction in general. And so that's one of the biggest stereotypes that we have to combat is when I see people that have all that and they're like, man, how did I get here? Like, I shouldn't be having to go through this. I have all these nice things. I have all the family support in the world. And we have to like kind of tell them like, hey, like anyone can go through this, So that's one of the bigger ones.
Yeah.
Do you feel like that is where shame also comes in? Because we have these stereotypes, these misconceptions of people, and then that's why addiction a lot of times stays hidden and we don't find out about it till later.
Yeah, absolutely. Shame is a big contributing factor because when people use, especially when they come from like a good family, they just want to like isolate. Like, I don't want my parents knowing, I don't want my family knowing, so I'm just going to isolate this issue and deal with it on my own, and I'll get over it eventually somehow, some way without anybody knowing. And so we try to work on something in the field, we call it stigma reduction, where we try to reduce the stigma around substance use disorders or addiction. And that's through using like first-person language, someone struggling with addictive behaviors versus, someone is an addict. We try to kind of change how people think about it. So then that person is more susceptible to get help. They feel more comfortable asking for help. Kind of like when, I think a little bit before COVID it was happening, but with mental health, when COVID happened, then people started really accepting that mental health issues are a thing, that they're real, they exist, and counseling everyone should really see. And so hopefully my dream is that someday with addictive behaviors, with addiction, whether it's substance use disorders or gambling, sexual addiction, that it gets to that place where it's socially acceptable to ask for help. Yeah.
Help us understand the role that a family plays in addiction. I think a lot of times there's probably, we've talked about the misconceptions of people from an outside perspective, but family is much closer. What type of role do they play, and how can families better understand what that person that's struggling with addiction is going through?
Yeah, the family roles part it's always different. So it's kind of hard I've done groups talking about family roles and family systems, and not a lot of people relate to some of the family systems. Yeah. The main family systems we kind of talk about is if this person is struggling with addiction, right, then they were either a lost child, meaning their family didn't really care that much about them, or they were the child that had to be perfect, or they had to be the class clown of the family, things like that. Not everyone's like that. One of the things that I think can help for family members is having those difficult conversations, right? Having those uncomfortable conversations, no pun intended, obviously. But I remember listening to your guys' first episode of having uncomfortable conversations, and that can really help with the family's role, is having those uncomfortable conversations and having them quicker rather than later. It's really hard when someone's struggling with addictive behaviors and they grew up in a family that never talked about difficult things ever. And so when you have that standard in your family, it makes it easier for them to want to like isolate. So the sooner you have those conversations, the better. And that can play a big role in if someone's going to isolate or if they're going to ask for help, their comfortability.
So one of the things that we see, and I think you mentioned this with the brain chemistry changing, they become so desperate to feed that desire that they could do anything. I mean, whether that's stealing or, selling their own bodies in certain ways. Like I think that's maybe part of it too, where a family is looking at that and going, okay, well, they made that choice to do that thing, whatever that is. So like, how do you help people wrestle with that and cope with, well, yeah, they did make that choice, but they weren't in the right state of mind. Yeah,
sure. I think a lot of it has to do with empathy, and empathy is a hard thing to talk about, and it's a more difficult thing to teach too and inform, because empathy, I believe everyone can learn empathy and they can adapt empathy and their heart can grow to be empathetic, right? And that's like, as Christians, like, we're growing, we're changing every day. Jesus wants us to love everybody. He's the ultimate empathizer. And so we can all strive to be more like him. So I think empathy is one of the big things that can help them understand what that person's going through. And boundaries are also huge as well. But just being able to always have that open space of, like, I get you're struggling, but I'm always here to talk with you through it. And empathy is what's...
Because one of the things I think we heard even Dan say last week several times was just how it was so painful, but he just needed to kind of let his son find his own way. And is that, I mean, from your opinion, is that what you find a lot of times has to happen for people to find recovery?
So,
or is it different, I guess?
I guess I think it's different a little bit. One of the things that kind of I see a lot is when I worked in a residential treatment setting, I would see a lot of patients or clients that would come in that if I were to do a diagnosis on them, treatment wouldn't have been my first spot. And so I value that if you're a parent trying to help your kid figure out what to do with their addiction or addictive behaviors, that they get an evaluation first to see if that is the appropriate level of care. Some people that have, let's say you have a drinking problem, you drink every day, not that much, quote unquote, but you go into a treatment center and these people have lost family members. They've, their life is all the way at the rock bottom, right? And you're going to go in there and be like, oh, I'm not that bad. Or, I wasn't drinking that much. So like, really, do I have a problem? No, probably not. Like, I'm good. And so I think a lot of parents rush to send their children or send their loved ones to treatment, to residential treatment, where they may need something like, maybe they just need counseling, or maybe they need to do intensive outpatient treatment, or if it's opiates, maybe they need medicated assisted treatment. Maybe that'll help them. So I think the appropriate level of care is huge. And that's what I see a lot.
Okay. I think from families, we talked about the shame of the addict, but I think from family perspective, there's a lot of shame in, hey, what are that person going to say about me, or what are they going to say about the environment? I think especially as a parent, like as I'm raising kids, I'm like, I am not perfect. And I probably unknowingly am pointing them towards traumas or pain points and, things that they're going to have to think about that shape their hearts and shape their lives more. And so I think a lot of times as a family, we won't even suggest maybe counseling or be willing to go with them and say, well, I have to admit I'm a part in some ways of the problem because I have my own shame that goes into it. How do I help? And so I think, that's good. And that's another, I think from a family perspective, you're bringing up the shame of someone addicted, but I think a lot of shame comes for the family and talking about it. And Dan talked about that last week as well. So I'm curious, just obviously you've talked about Jesus and your faith is a part of, I'm sure in some ways your practice and your influence and how you approach counseling. How does your walk with Jesus affect how you understand this, how you see it, and how you approach treating people.
I know for a fact I couldn't do this field without him. I rely on him every single day because I have clients that don't do better. I have clients that do better, and he helps me stay grounded in knowing that what I'm doing helps, right? That I'm giving hope to them, right? Jesus is hope. He gives me hope. He gives a lot of us hope. And when I see someone coming in and they're struggling really bad and they've lost everything, I might be the only person giving them that hope. I might be the only person that they speak to that is giving them some sort of life that's telling them, hey, like, we can get through this. You can get through this. You can do this. And without Jesus, I know I couldn't do that because it's just really taxing. I'm sure you know, working in counseling, like, it can be really hard to separate that. And so I rely on him to do that a lot. And yeah.
Yeah. Have you seen like faith play any pivotal role in people's, I mean, can you tell maybe in clients like, hey, when there is a faith, this is helpful or it's not helpful? Like, do you have any anecdotes or stories of just seeing that happen? Or is it mostly like, hey, personally, and I get what you're saying there is like, man, I can provide the steps and provide all the tools. And it's just frustrating when it's like, this person took off and they found freedom, and this person with the exact same, advice and everything, they just keep finding themselves in a rut. So you have any of those stories or thoughts of how you've seen that play out?
Yeah. So one of my first ever clients I had, I think he was either my second or third. We had some pretty deep biblical based conversations when it was coming to his addictive behaviors. And I'll always remember him because we had really good convos. I felt really happy. He was a super nice guy. He would be very like reassuring that I was helping, right? Then one day I get a phone call from my supervisor at the time who tells me that this specific client got arrested, went back to jail. He was court ordered, went back to prison. And I remember being very heartbroken, but I remember either God was telling me, someone was telling me that what I did helped him. And he had a friend that was in the group, and he would tell me and give me updates. Hey, so-and-so wanted me to let you know that he's doing okay, that he's doing good. And he would check in with me like every other month, just telling me, hey, my friend's still doing good. He just got out. He's doing great. And that story to me is what makes me, like, reassures me that I'm like doing the right thing.
That's cool.
Yeah.
Yeah.
And it's more of like an interesting story because this person, I haven't heard from this person since I left that job, but this person like went back. Like, he went back to jail. He wasn't like a success, quote unquote, story, but it was a success to me because you can go back and forth with this thing, but as long as you keep trugging along and keep doing the steps, then you can be successful in it.
Yeah.
And I think even before you mentioned having empathy, and even in that, like, you don't even have to talk about or bring up Jesus to show someone empathy, or even just the different characteristics of Jesus.
Yeah.
And even like in my counseling practice, like, I'll always like find a chair and I'm like, even if like we're not acknowledging Jesus, like, he's there and he's in the room. And I think that gives a lot of support to us as therapists for that.
Absolutely.
I want to talk a little bit about recovery and what that looks like. Do you have any advice for someone maybe that is listening that is currently struggling with addiction? What are some resources, like something easy, like a low hanging fruit of like, I don't know what to do. Like this, like reaching out and doing this feels super complicated, but what's something like a first step? Even I always focus on in therapy, like, what can we do to move the needle like 1%? Like, you're not having to go all the way and fix everything in one day, but what does that look like for you? What are some thoughts that you have around that?
Yeah, absolutely. So I know you talked about last time, like the crisis number, right? The 988 number.
Yeah.
Good resource to call them if you really do not know where to go or know what to do or know what resources are out there. I advocate that you call them. If you have technology, do research, figure out, okay, my first step would be, let me get an evaluation set up. If resources are low and I have no money, there's like the Stevens Center has a hero program where they charge like $25 for an evaluation. Evaluations can be really expensive. So if you don't have the funding or resources, do that. Check to see what you can get for state like Medicaid or things like that if you qualify for that. a lot of the first steps when it comes to it is figuring out what resources you have and what's available to you. If money's not a problem and that's not the issue, then find your nearest substance use counselor, get an evaluation done, and see what you need. Do I have a problem? How intense is that problem? Right? Because if I were to go to like a family member, a lot of times, like I said before, they may just say, okay, we're just going to drop you off here and you're going to do residential treatment for 30 days. And maybe that's not what you need. So figuring out what it is you need is a really good first step for someone who doesn't know, because it'd be very overwhelming when you're going through this. And the only thing you could think of is like rehab. But there's other things besides rehab that you can do that can be helpful.
Yeah. I feel like everybody needs to like pause, rewind 60 seconds and listen to that, because that is such a missed part of the therapeutic process, is knowing that, okay, between my addiction and figuring out what I need to do, there are people that are trained in therapy specifically that can give you an evaluation. It's based in research and it's very helpful. Like it gives you, it lays you out on a piece of paper. And I feel like that not a lot of people think about that when we're going through the process, even family members of like, yeah, we're just going to go right here. So I'm like, everybody listen to that.
Yeah.
You mentioned a little bit too that you're working in the medical assisted treatment. And I also think that's something that maybe not a lot of people know about. Can you talk a little bit about that just as a resource and maybe dispel some misconceptions about that?
Yeah, absolutely. So medicated assisted treatment focuses on the opioid, heroin, and specifically now the fentanyl epidemic crisis that's going on right now. So what medicated assisted treatment does is we use fentanyl and we use buprenorphine to help with opiate use disorders or fentanyl heroin. So it first started, methadone, the substance itself was invented in the 1940s and then was a federally funded medicated assisted treatment tool in 1974. So methadone is a Schedule II narcotic. For those of you that don't know, Schedule narcotics is the way that but the general medical field generalizes different medications to figure out how addictive they could be and how medically acceptable they are. So a Schedule I narcotic has no medicinal value at all. So that would be like heroin, that'd be like LSD, like those substances do not have any medicinal value and can be highly addictive. Schedule II narcotics, opiates, fentanyl, methadone, have a high risk for abuse, but do have some sort of medical value, right? And with opiates, fentanyl, and methadone, it's for pain. So what makes medicated assisted treatment a really good tool is because methadone is an opioid agonist that essentially will attempt to take away the withdrawal effects that you get from fentanyl and opiates. Fentanyl withdrawals are really, really, really strong. Right now, I would say, depending when people are getting from the streets, they're probably stronger than the opioids are because you've got so much in fentanyl now, and fentanyl's mixed with so many other things that there's a lot there. So what makes it non-addictive, and one of the stereotypes out there is that methadone is just a drug replacement or another way to get high or a way for a doctor to get you high, essentially. With methadone you can get from a physician, just a regular psych physician or a regular physical pain physician for pain. What you can't get methadone for is to help with your addiction without doing medicated assisted treatment. So if I went to a primary care doctor and said, hey, I'm struggling with opiates, can you prescribe me methadone for my addiction? They'll say no. Because what medicated assisted treatment does is we have counselors, doctors, and the counselors kind of provide the case management part of it, and they're dosing you your methadone every single day. And we follow the 3 phases. Introduction is getting them in the door. Stabilization is getting them to a stable dose. If you're using fentanyl, the doses have to be a little higher. And that's the difference between methadone and buprenorphine or Suboxone or what you'll see on the commercials. Those doses for that, because that's a Schedule III, those doses only go so high, and fentanyl requires a little bit extra of a juice. So that's where methadone would come in for that. So then once we get the stabilization part down, then you're in the maintenance stage, and the SAMHSA regulations now are anywhere from 12 to 24 months. After 24 months, then we could start looking at tapering down to where you have 0 milligrams of methadone and you're no longer using methadone anymore and opiates, and like you're good, you're sober, living that recovery lifestyle now.
So is a doctor administering the drug every time, or
So,
because they're not? I would assume they couldn't be trusted to do it on their own.
Yeah, that's a really good question. Someone who is in that stabilization phase, trying to get that dose, they're coming in every single day, Monday through Saturday, to dose. They get one take-home dose on Sundays, and then they get a take-home over like a holiday, or if we were to close the clinic because of weather restrictions or something like that.
They never get like a bottle of pills, pretty much,
No,
right?
They wouldn't unless they're in the maintenance phase where they qualify for that. So that means that they've been illicit substance free for at least 90 days, and that they have a stable home environment, that they're doing their counseling like they're supposed to be doing. They have to fit federal guidelines in order to get take homes for that. And we use liquid form. So the liquid form is a lot better because they'll just go into the pharmacy and the pharmacist will pour it out, and then they drink it there and then they go. Pills, with people that struggle with substance use disorders, they'll cheek them. They'll walk out of the clinic and not take it and start selling it on the streets and do those things. So I don't know if that's the exact reason why we do liquid, but I know that's something as a counselor that I value about doing the liquid.
Yeah.
And so, and part of that process are you drug testing them, or are they having to be drug tested to make sure, okay, you're not using this plus, fentanyl, or you're actually staying on that in that process?
Yep. So that is what's important about the counseling side of it, is we make sure that they're getting, we make sure that's in the system, that they're getting UA'd frequently and randomly, right? So they have no idea when it's happening. We as counselors, we could look, but we really don't know. And I never look to know. I want it to be random too. And then I feel like I'm not lying to them saying I have no idea because I never look. But yes, we do the UAs that are random. And then when someone's still using, because that can happen and it happens frequently now, then we're going to get that dose higher. And we're going to talk to them and be like, hey, so you're still, using fentanyl. What's going on is you're still feeling these withdrawal symptoms. And if they're still feeling withdrawal symptoms, then we increase their dose until they no longer feel those symptoms anymore. And then once we see those negative drug tests, then you get what's called the stabilization phase. And then we wait the 12 to 24 months from that point before we as clinicians recommend tapering off of methadone.
And sorry, one other question, just because we're using the term withdrawal, and I think a person that just doesn't know, I've withdrawing caffeine. I mean, I think we have our own thoughts of it, and I get a caffeine headache, and how powerful are those? What does it do to the body of somebody that it's not a 20-minute headache or whatever it might be? What are those powerful withdrawals? And you were even saying fentanyl would cause even more long lasting and more powerful withdrawals. And so can you just describe, from your clients and so on and so forth, what that looks like for somebody that has no clue when we're using that word?
Yeah, absolutely. So withdrawals, they differ depending on what substance you use. So before fentanyl and opiate withdrawals, what was out there was that withdrawals from alcohol are actually the most severe ones. You can get tremors, sweating, anxiety, nausea, all those things. Opiates and fentanyl, same thing. Fentanyl a little stronger. So you're going to experience a lot of sweating, excessive sweating, puking, nausea, throwing up, headaches, physical body pain that you're feeling. Dan kind of talked about last week about when his son came over 2:00 in the morning, I believe is what the time was. And he was sweating, nausea, super sick, and throwing up everywhere, and just needed a place to stay. Let him in his house, was throwing up, all those things. In my brain, when I'm watching that episode, I'm thinking, oh, he's going through withdrawals, meaning that he hasn't used fentanyl or opiates for a significant amount of time. And like I talked about earlier, how your brain relies it needs it because of those fake endorphins. That's what the withdrawals are. So when someone doesn't use, then that's what they're going to feel. That sweating. The sweating is a big one. Nausea is a big one. Throwing up's a big one. I'd say those are the three common ones with fentanyl, for sure.
Thanks.
So if I have a family member and I have a pretty good idea that they're struggling with addiction, how do I go about that? Because I think depending on your relationship with that person, you can come across judgmental or condescending, or what's the best route to approach that?
Yeah, that's a really good question. I would say, how have you had those conversations before? Those uncomfortable questions? How have you created that non-judgmental environment before? Because that's really going to deter how you have that conversation with them. I talk about, like, I mentioned off camera, I have a 9-month-old daughter, and even being in the field, I'm always thinking, like, if she starts struggling, like, how am I going to have that conversation with her? Yeah. And it's about what I do now and as she gets older of having uncomfortable conversations with her, creating a non-judgmental environment. Recognize kind of how it affects you, right? And having awareness of, like, okay, how am I being affected by this? And how can I separate that from when I have the conversation with them? Because it's really hard to do that if you don't think about it. It's easy as family members to go into it with a little bit of anger and frustration, resentment, because we're like, how did this happen? And like, it makes us upset. Yeah. So we kind of have to deal with that too. And the best way is just having that empathy, non-judgmental voice, and really having that caring eye and look of, like, I just want to, like, to help you. Is everything okay? Is there anything that you're struggling with? And if that answer is no, then, like, respecting that, even if you know or think that it's something different.
And how does a family member take care of themselves through all of this? Because I think it's one of those things where whether they're receptive or not to your help, it affects everyone, and it's a stressor. It creates resentment. How do we handle that?
Well, for anyone that's out there that's watching this that is struggling with a family member, your feelings are all valid and they're all justified feelings. I would say the best thing to do is to seek your own counselor, get your own therapy. If you have a loved one that's struggling, there are resources out there. They're called Al-Anon meetings. Those are family group meetings with other family members that are also struggling with loved ones that have these addiction-related issues, and they're all talking in a circle, similar to like an AA meeting. They're all talking about it and supporting one another and supporting each other. That is the best way to do it, because you also don't want to feel alone in this either, because you're not. There's a lot of family members out there that are struggling with this, and you're not alone either. So I think that'd be the best way.
And how about creating boundaries? You know, I think Dan talked about that last week, and that for families can be a very difficult thing, because you love somebody, you're super empathetic towards them. Maybe, dad, and in that case, Dan and dad and mom have differing views on this. Mom's like, you're just abandoning our son. And dad's like, that's the only way to help him. So how do you help people create boundaries around those types of things when maybe somebody isn't wanting to get help or seek treatment, and, they keep relapsing and using and choosing not to take advantage of maybe the help that you're trying to offer them? Do you have any advice on that?
Yeah. Boundaries is hard, because in order to set healthy boundaries, we have to first, as a family, so if it's a child of mine, we have to accept that this is who our child is now. We have to accept that this is who they are. This is part of their story. This is going to be part of their journey now. Whether they continue using or they get sober, this is all part of their life story. And so in order to set healthy boundaries, we have to start there with accepting that this is our life now and this is our family. Boundaries they're hard because of all the reasons you said. You want to help them. You want to love them. You don't want to enable them. You don't want to make sure that they're getting their needs met. You don't want to give them money, put them in housing, because they're just going to use it to fulfill their addiction-related issues. So boundaries are meant to protect you and protect your family. So protect you in your marriage, protect you and other siblings. Boundaries are meant to help you, and it's also meant to help them. And the best way to set those up is having those conversations with them about these boundaries and why these boundaries are being set, and being really smart about how you address those boundaries. Yeah. Being clear. And
I will even in session reframe how we talk about a boundary of a boundary is not necessarily we think about it as keeping somebody out, but a boundary can be, what do I need to stay in relationship with you? And so in order to stay in relationship with you and keep you in my life, these are the things we need to do as boundaries.
Yeah.
That's good. Wow. It's so much to cover, and a lot to retain. And I think it's probably a lot for people to process through, depending on where they're at in this. Maybe if they're just hearing it for the first time, I think it's beneficial to build that empathy, like we'd mentioned, to hear the realities of it and what it really means. But I guess as we wrap this up, is there any closing thoughts you have, or any resources you want to point people to, or if you want to give a referral to yourself, where can they find you at? Give us some of that information.
Yeah. So if anyone out there is like struggling, doesn't know what to do, right? Whether you're struggling with the addiction yourself, or you have a family member that's struggling with it, you can always contact me. My phone number 402-235-8341. You can always give me a call. You can always text me. I will be more than happy to at least try to guide you in the right direction of how to help. If you're struggling, as long as you live, you can still keep fighting. There is hope. Treatment works. Whatever level of care of treatment that is, it does work and it can help you. If you find that it helps you, but then you steer back, you can use that as a learning opportunity, figure out what went wrong, fix that, and then keep moving forward and continue again. It's a never-ending journey until we don't have air to breathe anymore. So we always have an opportunity to get better and get healthier and live a life that we want to.
That's good. That's good. All right. Thanks, Corey. Really appreciate your time. Great to have you here. Great insights. If you have any questions or concerns you want to reach out to us, you can always do that on social media, on Instagram or TikTok at CCCOMA Podcast. You can send us an email to podcast@cccomaha.org or leave us a voicemail at 402-885-9930. But until next time, we'll talk to you then.